let's talk about occlusion, part 1. So the first thing I want to do is I want to thank everybody that is here with us today in the morning. We are recording live from Fort Myers, Florida, and we want to make sure that you do follow us on all our social media platforms, which include our YouTube channel, our Instagram account, and our Facebook account. We also want to thank Colteen, Oral Arts Dental Laboratories, and DentLogix for making this webinar possible and for allowing us to provide 1 free CE credit for anybody that would complete the quiz at the end of my presentation. And just so that you know how to complete the quiz, you have to visit our webpage, www.romerodentalseminars.com. Then you're going to click on the webinars link, and at the bottom of that link, you will find that CE quizzes. The quiz for today's presentation is uploaded in our webpage. All you need to do is download it, fill up all your information, answer the questions, and email it back to us at romerodentalseminars@gmail.com. Again, one very important aspect of our webinars is our YouTube channel. Every webinar that we have is recorded and then it's uploaded in our YouTube channel. So if for whatever reason you want to review something, you can always go back and they have completely free access to all our webinars. So make sure that you hit that subscribe button when you visit our channel, so that way you can get notifications, free notifications on every single video or webinar that we upload in our channel. And I want you also to remind you that in April, that's going to be our second webinar, part 2 of this series of occlusion, of webinars in occlusion. And this part 2 is going to talk about composite prototypes. That will be Saturday, April 22nd of this year at 11 in the morning. Also, you can sign up for this webinar visiting our webpage, www.romerodentalseminars.com. Our learning objectives for today in the morning: after viewing this webinar, the participants should be able to, number 1, remember the anatomy of the TMJ. Number 2, understand centrogulation. Number 3, apply the concepts of centrogulation when obtaining a bite record. And number 4, understand the Coy's phase bow and use it clinically. So let's get to it. So the first thing I'm going to do is I'm going to very quickly review what the temporomandibular joint, the anatomy of the temporomandibular joint. This is very important for us to understand everything that has to do with occlusion, everything that has to do with centrogulation, and how can we apply this in our clinical practice. So the first thing that I want to review is the most important aspect, in my mind at least, of the TMJ, which is the glenoid fossa. And it is important for us to understand the anatomy of the glenoid fossa for a couple of reasons. But the number one thing that I want you to remember is this little fissure that you see that crosses right in the center, or approximately more towards the back of the glenoid fossa. And this fissure is called the Glaser fissure. And this fissure, what it does, it actually divides the glenoid fossa in 2 portions: the articular portion and the non-articular portion. The non-articular portion is going to be towards the back of the glenoid fossa. The articular portion is going to be towards the front of the glenoid fossa. When you look at the photo on the right-hand side, you can see this shaded orange shade triangle that I have placed in this glenoid fossa. And the reason why I have placed this triangular shape orange shadow in that glenoid fossa is because that is really the shape of the glenoid fossa. The glenoid fossa is wider towards its base, towards the outside, and is narrower or sharper towards the midline of the patient. So this is crucial to understand, because when you look at the actual anatomy of the eminence, articular eminence, going into this, to the condyles going into this glenoid fossa, the condyle also has what we call the medial pole. And that medial pole of the condyle is actually the one that determines centrogulation, meaning that the medial pole of the condyle is going to sit bone braced in that medial aspect of the glenoid fossa. And it's only on that anterior aspect of that glenoid fossa where all the function occurs. And this makes all the sense in the world, because if you think about it and you remember about anatomy, remember that behind or distal to the condyles, you have retrodiscal tissue that has nerves, that has vessels. So you mean there's that's where all the innervation of the actual structure comes from, and you don't want to have any pressure from the condyle in that area. That's why that area is a non-articular area, and it's going to be a lot easier for you to visualize this when we go ahead and look at a cross section of the TMJ. But again, on the right hand side, you can see the glacier fissure. And most importantly, this is where the condyle actually functions. That's the way the condyle actually sits within that glenoid fossa. And you can see that that medial pole of the glenoid fossa is of the condyle is the one that sits in that vertex of the glenoid fossa. Distal to that, it's always going to be tissue, retrodiscal tissue. You should have no pressure in that area. And this is why it is so important when you're actually taking your patients from maximum incruspation to centrifugation, that you don't want to you never want to try to push that chin backwards, because when you're pushing the chin, when you're doing the chin point manipulation and you're pushing those condyles back, they're going to be now invading that area, that non-articular area, creating pressure on this valued and nervous tissue that can also cause pain to our patients. So always keep that in mind, and we're going to review this when we talk about the actual concept of centrifugation. And again, on a cross section of the temporomandibular joints, I just want to, again, we don't want to go into any depth here because I know you guys know this, but I just want to pinpoint some areas that I think that we should always keep in mind. I want to pinpoint some anatomical structures that we always have to keep in mind, because when we are seeing our patients, when we are trying to take our patients from maximum incruspation to centrifugation, we have to understand this anatomy. We have to have it in our mind, so that when we're actually manipulating our patients, we understand exactly why and what they are feeling. So the most important aspect of this cross section is this part one, which is the interarticular disc. This interarticular disc that is biconcave, you can see has two concave areas. And the most important thing that we have to understand is that the loading area of this disc is a center or the middle portion of the disc. You can see that towards the back and towards the front, those are the ends of the disc. There is no pressure in those areas. The disc and the condyle disc assembly have to be correctly aligned in order for you to be able to say that your patient is in centrifugation. And this is going to be the position, the centrifugation position, that we're going to use for any major rehabilitation of the stomatognathic system. Now, the other elements that you have to understand is the inferior lateral pterygoid muscle, which is crucial, because this inferior lateral pterygoid muscle, every time that it contracts, it actually pulls the condyle down and forward against the eminentiae, which means that the superior lateral pterygoid muscle has an opposite function, meaning that when the inferior lateral pterygoid muscle contracts to bring the condyle down and forward against the eminentiae, the superior lateral pterygoid muscle needs to shut off. It needs to be completely relaxed so that it will allow the disc to be pushed distal by the I'm going to show you right here. This is the vasculature, retrodiscal vasculature. But this ligament right here, the retrodiscal ligament, this one and the superior lateral pterygoid muscle are the ones that maintain the correct alignment of the condyle disc assembly. When you are opening your mouth and the inferior lateral pterygoid muscle contracts, the superior lateral pterygoid muscle relaxes its contraction, and the posterior ligament actually contracts so that it maintains that condyle disc assembly alignment. And this is again crucial. We have to understand it, because if we know this, if we understand this portion, when we're actually manipulating our patients, when we're actually taking them into centrifugation or registering centrifugation for any of our full mouth cases, or for any type of restorations that we're going to do on our patient's mouth, we are going to be able to interpret those signs and symptoms and understand what's going on, what's going within their TMJ. So that's why these elements are so important for us to understand. So again, I'm just going to repeat them. You have the interarticular disc, you have the inferior lateral pterygoid muscle, the superior lateral pterygoid muscle, and the retrodiscal disc. Those are the most important elements that we have to keep in mind. And obviously the position, the centrifugation position, which we'll discuss shortly. And actually, we're going to get into it right now. We're going to actually now talk about centrifugation, because now that we know the anatomy, now that we kind of understand the way and the shape, the way that the glenoid fossa is shaped, and the way that the condyle, the medial pole of that condyle sits in that medial vertex of the glenoid fossa, we now have to go into the actual concept and see, try to understand this concept of centriculation. Now, there's many schools of thought in regards to occlusion. I always tell, when I'm talking to my colleagues, I always tell them, we have to decide for one. It cannot be that in a practice you're going to use 10 or 15 different philosophies. So I have chosen this philosophy, the Dawson philosophy, the Dawson concept of centriculation, as my primary objective every time that I'm going to go ahead and restore a stomatognathic system, regardless of the type of restorations that I'm going to do. And the reason why is because I feel that this is the one that in my hands and in my mind, it makes more clinical sense. At the end of the day, we have to make clinical decisions every single time that we are with a patient. So let me just go ahead and read what Dr. Dawson wrote in his textbooks in 1985 about the concept of centriculation. For him, centriculation is defined as the most mid-superior and anterior condylar position in relationship with the fossa, irrespective of vertical dimension and teeth position. So this is very important for us to understand. See, centriculation is a condylar position. That's what we're trying to register when we are getting a bite registration in centriculation. We're not trying to register the position of teeth or the vertical dimension. We're actually trying to register the position of teeth when the condyles are in centriculation. So it's the condylar position what we're trying to register. And this is very important because now we're going to go ahead and break down this concept. Why is it the most mid superior, and why is also anterior in regards to the position of? Look at the anatomy. Okay, I'm sorry. So when you look at the anatomy and you look at the muscles and the way that they interact, you will understand why is centriculation the most superior and the midmost position of the condyles in its respected fossa, irregardless of tooth position or vertical dimension. Now, if you look at these photos, let's look at the first drawing on the on the left hand side. We're looking at the masseter muscles, and we're looking at the direction of contraction of this muscle. And when these muscles contract, you can see that the only way that they will guide that condyle is up and slightly back, up and slightly back. And if you look at the photo on the right hand side, you can see that the medial pterygoid has its direction load towards the midpoint, towards that vertex of the glenoid fossa. So this is the reason why that medial pole, and you're seeing it right here on this right hand side, the medial pole of the condyle is bone braced against that vertex of the glenoid fossa. This is how we determine that superior and midmost position. And as you can see, these both positions have nothing to do with they have everything to do, I'm sorry, with physiology. They have everything to do with the direction of load of these muscles. So the centriculation position has everything to do with the way that the muscles actually work in physiologically. So it's not like you are placing your patient or you are forcing your patient into centriculation. Centriculation is something that happens in a natural way. And it happens in a natural way because it just follows that contraction, the direction of load of these muscles, the elevator muscles. So this is very important for us to understand, because when we are actually loading the condyles, when we are doing the bimanual manipulation described by Dr. Dawson, and we are trying to register that centriculation position, we have to think about these muscles. We have to think that we have to load those condyles just like these muscles load them physiologically, because this is the only way we're going to understand what centriculation is all about. Now, there's one other muscle that I want to I want you to see here on this on the left hand side sketch that I have here. And you can see that there's a minus sign in the inferior lateral pterygoid muscle. Why is that there? The meaning of that minus sign is that, or negative sign, is that this muscle is completely relaxed when the elevator muscles are loading the condyles. Again, this muscle, the inferior lateral pterygoid muscle, is completely relaxed when the elevator muscles are loading the condyles in centriculation position. This is a must. So when we talk about which one is the muscle responsible for allowing the condyles to fully sit in their bone brace position? The answer to that question is always going to be the inferior lateral pterygoid muscle. Because when centriculation and maximum intercrispation do not coincide, normally it's because that muscle, the inferior lateral pterygoid muscle, does not release its contraction. And this will prevent the condyles for fully bone brace sitting up in the glenoid fossa. So again, you have to understand this physiological pattern that happens with these muscles so that when we go to patients, we can, we can see this happening, we can understand their symptoms, and we can help them, relax these muscles so that the condyles can get all the way up the eminentiae to their bone brace position. So that is what it has to do with the theoric, the theory part or the conceptual part of centriculation. But at the end of the day, me and you are all clinical. We are seeing patients every single day. I see patients 4.5 days a week. Many of you see patients 4 days a week or 5 days a week. So we're seeing patients every single day. And when these patients come to us with a problem, when they come to us with muscle pain, when they come to us with signs of instability, hypermobility, excessive wear, abfraction lesions, so many things that can be happening that happen every single day in our patients, we have to have an answer for that. We have to make sure that we can go in and verify, okay, where are the condyles now? And does the condylar position that the patient presents to in your practice, does that have anything to do with what you are seeing clinically as evidence of of something going wrong, something not working properly, the excessive wear or the hypermobility or the hypersensitivity of teeth? Does one thing have anything to do with the other? In this particular patient that I'm sharing with you right now, on the left hand side, you are seeing the photo of the same patient in centriculation. Her chief complaint: she has muscle pain, facial pain, and she's having to take medication for it. In her teeth, there were minor signs of instability. Again, don't forget, the system is made out of multiple pieces. You have the teeth, you have the periodontal ligament, you have the muscles, you have the alveolar bone. Any of these portions of the system can fail. You can have, teeth breaking down, or teeth with excessive wear, or you can have muscle pain, or you can have bone loss. There's so many things that can go wrong when the system is not working properly. And that's what we have to try to figure out, what is happening with each and every one of our patients. In this particular case, she had very minor signs of instability in her teeth, but she had a huge sign of instability in her muscles. She had muscle pain. And what you're seeing on the left-hand side is me after, relaxing the inferior lateral pterygoid muscle. Because again, if the inferior lateral pterygoid muscle does not relax its contraction, the condyles will never get to centriculation. That's something that we have to understand, because this is not a concept. This is human physiology. This is the way that these muscles work. So in the left-hand side, I have already relaxed the patient, and I'll show you how I do that. I have already relaxed that muscle. Maybe it took me 20 to 30 minutes to get full relaxation of the inferior lateral pterygoid muscle. Sometimes you just cannot accomplish it during your chair time visit with the patient. But in this particular case, I was able to, maybe 20 to 30 minutes, relax those muscles. Once the muscles were relaxed, and I'm going to show you how I know they were relaxed. How do I go about, making sure that the muscle is either tense or relaxed? Once I do that, then I go ahead and I do the bimanual manipulation, and I load the condyles. And when I'm loading these condyles, I'm following exactly the direction of load of the medial pterygoid and the masseter muscles. So I'm loading these muscles just like the elevator. I'm loading the condyles, I'm sorry, just like the elevator muscles do so. And that's what you're seeing on the left-hand side. You are seeing that the patient is now contacting one molar, and it's actually the maxillary right second molar. Is the only two, with the opposing second molar, is the only two teeth in her mouth that are actually touching. And I want you to see what is the distance that she has between both arches in centriculation. You can see that left-hand side photo, at least there's 4 or 5 millimeters there, which means that when the condyles are in centriculation, there's only one tooth touching, and that tooth is not allowing the rest of the teeth to touch. And in order for this patient to go from centriculation to maximum intercuspation, when she clenches, and that's what you're seeing on the right hand side, that condyle is moving down against the eminentiae and forward till she can get into maximum inner crispation. And for that to happen, who has to contract? The inferior lateral pterygoid muscle. That is the muscle that is painful in this particular patient. And it's painful because that muscle never releases its contraction. And it doesn't release its contraction because this patient has a huge discrepancy between centric relation and maximum inner crispation. So let me just show you another case. How do I go about this diagnosis? How do I go about, okay, is my patient in central relation? So this is another patient. This patient also comes to me with pain, with muscle pain, and telling me that, she feels that there's some clicking and popping of the joints, and she's very uncomfortable. So again, I look at her teeth, not a lot of signs of instability. I go in, you are seeing now my index finger going into her mouth towards the side, distal to the second molar. That's where I can palpate intraorally the inferior lateral pterygoid muscle. And when I touch that muscle, I took this photo that you see on the right hand side. I had one of my residents take the photo, and they took that photo because I want you to see something. I want you to look at her eyes. And this is something that I find that is very common every time that I'm doing diagnosis. I just tell the patient, okay, they tell me their story, they tell me why they're having pain, they tell me what their symptoms are. I go in and I say, let me go ahead and check one muscle. I don't tell them what I'm going to do. I just go in with my finger very gently. You can see that I'm all the way distal to the second molar towards the buccal surface, all the way in the back. I have one of my right hand, I'm left-handed. My right hand is on her cheek. My left hand, my index finger is in her mouth, and I'm now palpating that inferior lateral pterygoid muscle. And I want you to look at her eyes in that photo. Those eyes are eyes of pain. This is what she is feeling when I'm palpating that muscle. And that muscle is painful because that muscle is never releasing its contraction. So if that muscle never releases its contraction, that means that that muscle is contracted 24 hours a day, 7 days a week, 365 days a year. No wonder it's painful. You see, that's what we want. That's what we need to understand. And now we know through anatomy and through human physiology that if the inferior lateral pterygoid muscle has not released its contraction, the condyles cannot go up the slope against the eminentiae, against the vertex of the glenoid fossa, and be in centric relation. That is crucial for us to understand. So what do I need to do in order for me to get those condyles to fully bone brace in the centric relation position? I need to make sure that the inferior lateral pterygoid muscle relaxes its contraction. And that's what we're going to do. And there's many ways that you can do this. I like to do it in a very simple way. I was trained by Dr. Peter Dawson. This is one of the ways that he did it, and I have found that this is a very useful and very inexpensive way to do it. Now, does it work every single time? No, it doesn't. It doesn't take the pain away in one chair time, maybe in 20 to 30 minutes all the time. It doesn't in the majority of the cases, but it doesn't do it in every single case. Sometimes I have to use something different. I have to use an anterior deprogrammer, and I have to send the patient home. Sometimes I have to help the patient with some muscle relaxants so that I can allow these muscles to relax with an anterior deprogrammer for 2 to 3 days, and then have them come back to my practice and now start all over, because now it's going to be a lot easier for me to relax. But this is a quick way of knowing, can I help this patient? Because at the end of the day, that's what you want to know. That's what me and you want to know. Can we help this patient? And an easy way, just grab 2 cotton rolls, put them at the level of the canines, and have the patient gently bite on them. This way, what you're trying to prevent is having any tooth contact. You're trying to eliminate the proprioceptive memory. You're trying to make the brain forget how these teeth come together, and allow the brain to forget that when they come together, the inferior lateral pterygoid muscle has to contract. So I put these cotton rolls, I have the patient just gently bite down on them and hold them there. I do it at the beginning for 15 to 20 minutes with just one time. I sit them down, put the cotton rolls, 15 to 20 minutes. I put a timer on, and I just allow the timer to tick. 20 minutes later, I come back into the room. I remove the cotton rolls, and I go back, and I'm going to palpate the inferior lateral pterygoid muscle for a second time. The same side that was painful. Sometimes you find both sides painful. Sometimes you only find one side painful, which is telling you a lot more. Now you know that only one condyle is out of centric relation and the other one maybe not, or maybe not as far down. So you go back and you palpate the same muscle that you did initially. And all you want to figure out is this, all you want to know is this: is the muscle still painful? And if the answer to that question is yes, is it as painful as the first time that I palpated the muscle? If the muscle is not painful, well, hey, you know that you just completely relax the inferior lateral pterygoid muscle. But let's put ourselves in the second option. Let's say that the muscle is still tender, but is not as tender as it was at the beginning. What is that telling you? It's telling you that the muscle is relaxing, which now tells me that she has a muscle imbalance. And muscle imbalances for occlusal issues like the one that she's referring to, for pain, for muscle pain, are fairly easy to and very straightforward to correct. So I can help this patient if the muscle is the problem. If it's an intracapsular problem, then hey, maybe it may be a little bit more challenging. You would have to have a little bit more experience to treat those patients, but you were able to diagnose. You were able to diagnose. You were able to let the patient know, you know what, this is not getting better, or it is getting better. This is only muscle, or it is not only muscle. And that's really what we should be doing. We should be diagnosing these cases and then making the decision, can we help them or not? And that is going to be based on our experience and our knowledge on the topic. So now you can see that I have been able to relax this patient. The inferior lateral pterygoid is completely relaxed on both sides, no more tenderness. So now I'm going to do the bimanual manipulation. And many of you would ask, maybe would ask, well, why, if the muscle is already relaxed, and by human physiology, I know that if the inferior lateral pterygoid muscle is completely relaxed, the condyle must be up the slope and against the bone brace position against the medial pole of the glenoid fossa, then I should be good. I should be in central relation. Well, yeah, you're right to a point. But now I have to make sure that the condyle disc assembly are correctly aligned. Not only that the condyles are in central relation, but that the condyle disc assembly is correctly aligned. And remember when we were showing you the graph, we had the superior lateral pterygoid muscle attached to the anterior border of the disc, and we had the retrodiscal disc, the retrodiscal ligament that is attached to the posterior border of the interarticular disc. These two elements are the ones that help maintain the correct condyle disc assembly alignment. For that to happen, the inferior lateral pterygoid muscle needs to be completely relaxed, and these two elements should be, fulfilling that correct alignment. But you got to prove to yourself that it is that way. And how do we do that? We do that through the bimanual manipulation technique. And in order for us to do that, we always put our patient in a supine position. I use my index finger and I just have them tilt their chin. And the reason why we do that tilt chin is so that they don't, because normally the patients are used to, when you tell them to bite down, they will protrude their mandible. You don't want them to do that. So you want to, lift the chin so that it makes it a little bit harder for them to protrude. You want them to be completely relaxed. You don't need any help from the patient. Again, these are the muscles working, and all you're doing is just guiding in that same direction of the muscle. You're not taking your patient to central relation. You are allowing the muscles to place the condyle where physiologically it needs to be. That's what we're doing. So you can see that I'm using now my forearm, and I'm just kind of bone bracing. I'm just kind of bracing her head between my ribs and my arm so that I have a firm position of her head. Now you can see that I'm starting from the angle of the mandible with my pinky all the way to an imaginary line that is going to be kind of at the level of the first molar. That's where your index finger should be. And that's where these four fingers are now on the inferior border of the mandible. Again, don't forget, I'm trying to load the condyles following the same direction of load of the elevator muscles. So that's what I'm doing here. You can see it on the left and right photos. And finally, I'm going to do that inverted C position of my fingers, so that you can see that inverted C that I put when I put my thumbs in the symphysis, and that is the position that I'm going to use to now just slightly hinge those condyles in their central glazing position. You should be able to hinge freely. Patient has to be completely relaxed. You're going to be able to hinge freely. Now, I have been asked many times, and I have been told many times by different colleagues, yeah, but this is not that easy. Well, nothing that we do in dentistry is easy. Everything takes experience. And you know how we get experience? We get experience by doing procedures. So just go ahead and do these procedures. There's many ways. There's textbooks. There's a lot of information out there on how to do the bimanual manipulation. Get used to it. Get used to feeling the muscles. Get used to putting your fingers on your patients. Get used to hinging that hinge axis, hinging that mandible, those condyles in the hinge axis. And now, once you start hinging, you're going to start putting pressure on that inferior border of the mandible towards the condyle. And you do 3 different intensities. And between each intensity, I ask the patient, is there any pain or tenderness at the levels of the condyles? And I literally point to them where the condyles are. And they say no. I go to the second intensity of pressure. If I ask them again, any pain or tenderness, if they say no, I go to the third level, which is now a lot of pressure on that inferior border of the mandible, pushing very strongly up. I literally tell the patient, you're going to feel like I'm going to lift your head out of the body, but I'm not going to lift your head out of the body, but you're going to feel a lot of pressure. If they are able to tolerate those 3 different, low to high intensity loading on the mandible, that means that the condyle disc assembly is correctly aligned. And why do I say that? Again, let's go back to anatomy. We know that posterior to the disc, we have retrodiscal tissue, which is nerves and vessels and some fatty tissue. If the disc is forward, it's in an off position, what's going to be in between the condyle and the fossa is going to be that retrodiscal disc, and that is going to be painful. If the disc is slightly forward, you're going to be now putting all the pressure toward the posterior border of the disc, which is also painful because that's where you have all the nerves and vasculature entering and giving nutrients to the disc. So now by anatomy, you know what's going on. You know that you need to allow for more relaxation of the muscles for everything to get back to normal. And that's why sometimes you're not able to do it in one appointment. You got to send the patient home. You got to help them sometimes with some muscle relaxants and with an anterior deprogrammer device that I use for just a couple of days, maybe 2 to 3 days. I don't use them for a long period of time. I just use them for a couple of days, have the patient come back, and we go back to the same procedures that I'm sharing with you right now. Now, for this particular patient, I was able to relax her in 20 to 30 minutes approximately. Once she was relaxed, then I was able to load the condyle with 3 different intensities. And every single time she said, there is no pain, there is no tenderness. So now I know that my condyle disc assembly is correctly aligned and that the medial pole of the condyle is seated bone brace position in that glenoid fossa. So now I'm going to have my patient slowly close their jaw until they feel the first contact. And what you're seeing on the right-hand side is the actual first contact of this patient. That it is not on the second molar, it is not on the first molar. You can see that there is a little contact on the first molar, but the heaviest contact is on the mesial incline of the lingual cusp of the maxillary first premolar. And you can see how heavy she's hitting that tooth. And that's the only tooth that is literally taking all the load when she is in centrifugation. So if you think about it now, and I have to make her comfortable, I have to keep those condyles in centrifugation. Well, this is a fairly straightforward case because if I do a selective occlusal adjustment with the condyles in centrifugation and eliminate any interferences to centrifugation, I have just made this patient, pain-free. So that's how simple it can be when you analyze these cases. Now, this is one of the simple cases. This is not every case is like this, as simple as this. But I want you to understand, and my goal is that I want you to put into perspective how much knowledge and understanding of the stomatognathic system can actually help you to deliver clinical care to your patients. Good, high quality clinical care. Or even if you're not able to deliver the care, at least give them a diagnosis. and let them know this is a muscle imbalance or this is an intracapsular problem that requires, different help. You are going to be that primary care that is going to guide this patient to where they can find help to solve their problem. But this only happens when there's a profound understanding of the way the stomatognathic system actually works. So now that we have, looked into the TMJ and we have spoken a little bit about centrifugation, let's talk about obtaining centric bite records. Because again, once, if you are new at this, if you are a younger dentist and you're going to get into this, you're going to have to understand, that there's multiple steps. And now what am I doing here? Look at the way that I'm hinging that mandible. My condyles are in centrifugation. She's fully hinging, completely relaxed. Now I tell her close down and bite. And you can see, I'm going to go ahead and play this video one more time. You can see how much she needed to translate her mandible from centrifugation all the way forward to maximum intercruspation. Again, for that to happen from an anatomical standpoint, the inferior lateral pterygoid muscle needs to contract. Look at the video again. I'm hinging the mandible. Look how nice and easy I can hinge. She's completely relaxed. Now I tell her bite down, and she bites down, and you can see how much that mandible protruded. It moved completely forward so that she can go from centrifugation to maximum intercruspation. And again, I'm going to show you now from a different view. Look at the hinge, centrifugation. I say bite down, and look at how much she was able to, she needed to translate those condyles in order for her to get to centrifugation. Again, one more time, hinging, bite down, and look at the way that the mandible moves forward. Now, I want you to look at this video, because if you think about it, if me and you think about this together, if she needs to move her jaw forward every single time she closes her mouth, and for that to happen, the inferior lateral pterygoid needs to contract, no wonder it is tender, or no wonder it is painful, because that muscle is never getting a break. This is what we have to understand from this video. So now, how do we register centrifugation? Well, there's multiple ways of doing this. One way of doing it is using a wax that is called the Delar wax. And there's one company that actually makes the original Delar wax, and you can Google it, you will find it, Delar, Delar. But there's also another company called Great Lakes Orthodontics that makes one very similar to the Delar wax, a lot easier to buy, because obviously, Great Lakes Orthodontics, it has a nice web page that you can go ahead and just order products from them. But the first thing that we do, you can see that this is like a wafer type of wax shaped. It's very, it's like maybe 4 millimeters on the front and maybe 2 millimeters on the back. So it has that little curve of spee included in that wax. It's a very rigid wax. You need to heat it, and that's what I'm doing on this video. Those are my hands. I'm actually warming up the wax just so that it absorbs a little bit of the heat and it can start getting a little bit soft. You don't want to overheat it. You don't want to, have the wax melt, because what you're trying to do is that you're trying to record the relationship of the mandible to the maxilla when the condyles are in centrifugation. That's really what you're trying to accomplish. And that's really what a bite registration is all about. All you're trying to do is get that relationship of the mandible against the maxilla with the condyles in centrifugation. You're going to use this wax in order for you to mount the lower cast on your articulator after you've obtained a face bowl. So with the face bowl and a centric bite record, you're going to get mounted cast in centrifugation so that you can do your diagnosis, or you can, you can fabricate an anterior guide, or just a bite splint. Anything that you want to do in that regards, you're going to have to do it in your articulator. So you see, once the wax is well heated and it's now soft, you can see that I'm using my fingers. I'm manipulating that jaw. I've already relaxed this patient. I'm manipulating the jaw, and now she's biting down. I'm guiding the closure. You see, she's biting down into the Delar wax without having any tooth contact. So I just have the patient, hit the wax. The wax is is very rigid, but it's now heated. So it does allow some, some alteration when she's biting down. And I tell her, are you touching it? Are any teeth in contact? And she says, no. I said, okay, bite just a little bit more. I want to have a space, maybe a 3 millimeter space between the maxillary premolars and molars, 2 to 3 millimeters, and the mandibular premolars and molars. You do not want to have any contacts. And the reason for that is because don't forget that every time that you have a contact, your patient deviates the mandible because they want to go to maximum intercruspation. That's what you want to prevent. Because again, you're registering this bite in centric relation. So this is one way. I love this method. It's the easiest one in my mind to learn because this wax is very dependable. It's very rigid. It doesn't melt easily. You can see that now I'm cutting all the excess of the wax out just so that I can keep the lingual cusp of the maxillary premolars and molars. And I keep the occlusal table and the lingual cusp of the mandibular premolars and molars. This wax is placed distal to the canines. I go ahead, once I cut it out, you can see that now the wax is already rigid, it's fairly rigid. I put it back in the patient's mouth. I have my assistant keep it up against her teeth, and you will see my assistant's fingers coming into play soon. There's one, and there's the other one. Now I'm going ahead and I'm manipulating that mandible again, making sure that the condyles, that I'm loading those condyles, that there is no pain or tenderness at that load, meaning that the condyles are fully bone braced. And now I make sure that I have the correct bite. And then I just have her open and close, open and close. And you can see that she falls into that centric bite record every single time. Because again, we have eliminated the proprioceptive memory by keeping those jaws apart 20 to 30 minutes, depending on each patient. I'm just removing any excess that I have on the wax, and I'm ready. I recommend putting this wax into very cold water just so that it gets nice and rigid. After you remove it from the cold water, put it back in your patient's mouth, make sure that it had no alterations, and then you're good to go to your lab and mount your mandibular cast against the maxillary cast. Another way of doing this, if you don't have access to the Delar wax, or you just want to give it a try first with something that you have in your office, is just using plain old Regisil, any type of bite registration PVS. Now, the only tricky part with this is that if you use Regisil, you got to keep your patient in that central relation position during the whole time while that Regisil is actually becoming it polymerizes. So you have to hold them there. Fortunately enough, this happens really quick. So you're not going to have to, hold there for more than a couple of minutes, but you got to make sure that they're kept in that position. And, I do it on the left, right, and front. Then I put them all three in the patient's mouth. I have them tap on top of them just to make sure that I registered the correct position. And then you can use the Regisil again to mount your mandibular cast against the maxillary cast into central relation. Now, how do you do this on a patient that has no teeth, or a patient that you're going to fabricate a denture on? And actually, Dr. DeRosa from the University of Rochester and myself published this case together in 2016, and we just kind of, this is the way that we came up with a good idea. He had this technique. I just helped him kind of take the photos and put it down into a piece of paper and make sure that we got it published. But this is one case where you can see that this patient, she was very unhappy with her existing denture. She felt that after using this denture for a while, she was developing this angular colitis. Some studies have shown that if your VDO is not correct, if you're overclosed, this is one of the signs of being overclosed, having saliva accumulating in your commissures, and obviously developing this angular colitis. So we knew that we needed to increase the vertical dimension, and we needed to make sure that we register central relation so that we can mount our cast in central relation and fabricate that denture in this position that we know is the best position that we can use, because it's the only repeatable position of the condyles that we can send back and forth with any dental lab. So what you're seeing here is the maxillary edentulous ridge, the remaining teeth that she had on the mandibular arch, and now we were going to make a final impression. We did a border molding compound, we did a wash impression for the denture, we fabricated a process base. And this is just a technique that I've been using for many years. I really like it because it just gives me this final denture base at the time of my second appointment. No teeth are on this final denture base. It's just the actual denture base. We put the PIP, we make sure that there are no excessive pressure areas. And now we develop this little very thin 2 to 3 millimeter thick wax rim that goes approximately from canine to canine. And we're going to do this so that we can have just a conversation with our patients. We're going to determine with this little thin wax where is the location of the incisal edge, how thick should it be, where is the how is that, where is the location of the lingual surface of these anterior teeth, where are they going to be located, where should they be. And all this has to do with phonetics and function. And again, I know that you guys know this very well. We have lips in repose just to make sure how much tooth display she's going to have with the denture. We have her in a full smile. Is this wax too long? Where do we need to have the incisal edges of these teeth? And you can see that we cut it down. We mark the midline. So we do all that with this little very thin wax because it just helps us communicate with the patient. The patient, that denture base is super nice and stable. This wax is replacing the teeth. It's not a very thick piece of wax. There's nothing on the back, which means that there's nothing interfering with the centriculating position of the condyles because there is no posterior wax rim. And now what we do is that we just have the patient swallow, and while they are swallowing, we inject bite registration PVS material in their mouth. Why do we do that? Why do we have them swallow? If you think about it, you swallow, I don't know, 100, 200 times a day. We don't even think about swallowing. Every time that we swallow, our elevator muscles are going to contract with the same intensity, and they're going to take a repeatable position of our jaw in relationship to our maxilla. That happens every single time, and it's an involuntary act, which we know that is physiologically driven by the muscles. So what we're doing on our dentulous patients, we also have them swallow. We allow the system to place that mandible against the maxilla where it needs to be based out of the physiology of the patient, and that's how we register our centriculation. So we're not putting the patient in, biting into any very thick and rigid wax. We're just allowing the mandible to fall where it needs to fall. And from that point, we can now increase or decrease the vertical dimension if we need to. In this particular case, we use exactly the relationship between during swallowing of this patient as our centriculation. And now we mounted our cast. We now measured from the bottom, from the base of the denture to the incisal edge, the distance, and we had 23 millimeters. And we asked our lab to place the central incisors or the incisal edge of our central incisors at 23 millimeters from the base plate of our denture. So we're not guessing anything. We know exactly where these teeth need to be. We know whether, because we've done this directly in the patient's mouth with that wax, that strip of wax. And we also know that the condyles were fully bone braced position in that centriculation position because there was nothing on the back of this denture base interfering with that position. So we're using all this knowledge, all these concepts to make this a clinical reality. And now you can see that we're just go ahead and try in, we do our denture wax try-in. This is the wax try-in. This is the completed denture base, the processed denture base with a wax up teeth. These teeth are just held in by wax in that denture base. And now we're doing phonetics, smile evaluation, lip support. We're doing everything we need to do. Do we always get it right? No, we don't always get it right. We sometimes have to move teeth here and there, like every single one of us. This is not a perfect science, but our starting point is a physiological starting point. Our starting point is with the condyles and centriculation. And if I have my condyles and centriculation, that hinge axis is not going to change. It's always going to be the same. It's repeatable. And I can now increase 2 to 3 millimeters without changing that hinge axis of the mandible because they're hinging in their bone brace position. So that's really crucial when you start looking into these cases and when you want to facilitate dentistry and you want to make sure that you're delivering care that is at a very high level of understanding of the way the system works. And again, this is just a before and after photo. You can see completely gone, angular cheilitis, a lot more natural, nice. She was very happy with the result. We were happy with the result. But the most important thing is not the aesthetic result. The most important thing is the functional result. And finally, let's talk about Facebook recordings. Because again, once you get your centric bite record, you're going to have to mount that mandibular cast against a maxillary cast that was also mounted into the articulator by means of a Facebook. Now, I personally use the Coy's dental facial analyzer, and I'm going to tell you why But what I do want to say is that the evidence has shown that using either a regular ear bow mounting ear bow type of face bow or the dental facial analyzer has not shown to have any statistical difference in the way that these models are mounted in your articulator. So for me, it has all to do with ease of application, clinical application. In my hands, the Coy's dental facial analyzer works faster and better than a regular ear bow type of face bow. And this is the study that actually showed this. And I just want to read out directly from the study the 4 conclusions that they came out with. The Coy's dental facial analyzer mounts the maxillary cast in a position that is not statistically different than the Pana mount face bow, which is from Panadent, when comparing the incisal edge position. Number 2, the Coy's dental facial analyzer mounts the maxillary cast in a position that is not statistically different to the Panamount face bow when comparing occlusal plane angle relative to the Frankfurt horizontal plane. Both the Coy's dental facial analyzer and the Panamount face bow locate the maxillary incisal edge position in a significantly different position compared with the dry skull. So there is a difference, and that has been reported. 80% of the times, patients fall into 100 millimeters, the distance from the axis to the incisal edge position, plus minus 5 millimeters. So we already know that. We know that but this is the same with the Coy's dental facial analyzer as it would be with any type of ear bow face bow. In this particular case, they compare it to the Panamount face bow. And finally, the 3-dimensional location of the maxillary cast varies approximately 9 to 10.3 millimeters at the condyle. So again, we also know that our mountings are only they're not 100% perfect. They are close enough so that we can apply them clinically. You would have to have a precise instrument that measures the precise location of that hinge axis and mount it through that apparatus in order for you to be more precise. But normally, in many clinical practices and in many PROS programs, this is actually a prosthodontic program where this study was performed at Marquette University. These are the articulators that we're using, and we're using just these values, these close enough values that have that they're going to be different than the actual patient. But that's why the final adjustment of anything that you do is going to be in the best articulator possible, which is the actual human skull. So again, how do you do the face bow? Again, I'm just going to walk through this step because I just want you to see an irregular ear bow face bow. How is it used and what is the theory behind it? You have the biting fork that you're going to register, all the your teeth on, and then you're going to have the face bow. You're going to connect all these together. You always need to have a third point reference. In this particular case, the infraorbital pointer. You can also have a Nasion. It depends on the type of face bow that you're using, and this varies from manufacturer to manufacturer. But in my mind, when I was using, and I still have these face bows, and I like them, but there's a lot of little things that you have to tighten here, tighten there. The patient is holding up to everything. If one ear is lower than the other, now the face bow is not parallel to the interpupillary line. If one eye is lower than the other, it's kind of hard for you to see if they're parallel or not. If the teeth are canted in relationship to the base of the skull, you're going to have to kind of see how you can register and keep everything the way that it is on the patient. In my mind, there's just too much steps when I compare it to my dental facial analyzer. But again, what are you trying to accomplish at the end is to use this to mount your upper cast on your articulator. And here you see now with the centric bite record, we're going to mount the lower cast. And once you mount the cast, you can go ahead and do any type of dental procedures that you would like. In this particular case, these are 2 overdentures. But what I want to talk about is the Coy's dental facial analyzer, and the reason why I like to use it clinically. And if you haven't used it, why not give it a try? If you're used to using if you're used to a specific face bow, do not change it, please. Just keep on using, because the evidence shows that you're going to get the same result with whichever type of face bow you're trying to use. But what I like about it is that, number one, you stand in front of the patient. Number two, the actual mounting plate has a little plastic has a plastic stop where you literally put that plastic stop in the center of the face of the patient. You align that with that facial rod, and this is what guides the Facebook. That's why it's called the dental facial analyzer, because you're using the facial midline to make sure that this is parallel to the patient's facial midline, and that's going to automatically make that the fox plane that you have on this face bow parallel to the interpupillary line. If there is a cant, well, the cant is going to be registered because you're looking not at the position of the teeth or the cant, you're actually looking at the facial structures of the patient to make sure that you're registering that facial component in relationship to this fox plane and the teeth and the maxillary arch. So that's the reason why I like it. There's no screws. I don't have to tighten here and there. All I have to do is look at my patient, stand right in front of them, make that little ledge touch the central incisors, make sure that the rod is flat and aligned with the facial midline, and I'm done. And I'm ready to go ahead and mount this on my palate. And as you can see, once the material is set on the left-hand side, you can see how this plastic uh, guide here is literally touching the facial aspect of the central incisors. The facial rod is aligned with the midline of the patient, and you can see how nice and parallel this fox plane is to the interpupillary line. So if the mandible is canted, you're going to register that cant, and the lab is going to be able to see the cant. And if you need to make any corrections, you're going to make those corrections in that mounted cast. This is the reason why I like using this specific Facebook, because in my hands it's a lot easier, less things for me have to tighten, and at the end I think that you may have less error also when taking the Facebook. But again, this is just me. There's no science behind it. This is just the one that I like and that I use, and that it actually comes and works very well with the articulator that I use, which is the Panadent articulator. And this is the same patient now mounted with my Cois face bow. I mounted the maxillary cast, and I used the Regisil to mount the centralization position of the condyles into that mandibular arch. And this is the final mounting of this particular case.